Okay, so the annual talk on bipolar disorder. Many of you are familiar with the condition, but of necessity, we have to start at the very basics because there are many people here who are attending a lecture like this for the first time. The purpose behind this talk is to give you a practical understanding of what the condition is, how it can be recognized, how you can become familiar with the signs and symptoms, knowing how often and why the diagnosis is missed, how it best can be treated, what sort of things people have to do in connection with lifestyle management at a practical, everyday level, and what are the final comments on staying well. So the first thing we start with is, well, what is bipolar disorder? Formerly it was known as manic depressive illness. Bipolar in its own way captures a certain essence of it, but in another way so did the word manic depressive illness, because what manic means is actually speed it up. The word depression, derived from the Greek, means slow down. So in essence that is the core thing of what bipolar is about. So in other words, that if you imagine that for a moment that we all operate mood-wise between these two lines, we can be excited about something and maybe other times down in the dumps about something, but it's only when you get down to this level that you experience depression of a clinical nature. In other words, it's about the severity of the symptoms. And up here, where a person would be in an elated or manic state. So we have a certain degree of variation, and it's only when a person's mood is going down here for prolonged periods of time or being up here for prolonged periods of time that one meets the criteria of bipolar disorder. So, in essence, it's a mood swing problem of a certain severity, and in essence, the severity of that is relatively disabling. Maybe not for the person themselves at that point in time, but maybe for people around them. In other words, that it's not just the impact it has on people. So, for example, the depression has to be present for circa 2 weeks and be pretty much there all the time. The elation, or mania, needs to be present for 4 days for what's called hypomania, in other words, little mania. And for a full-blown episode of mania, it needs to be present for at least 1 week. We'll come back to the signs and symptoms in a moment. How frequently does bipolar disorder occur? It depends on the way you define it, and certainly over the years what's tended to happen is that our understanding of how frequent minor degrees of bipolar disorder are present in society has expanded enormously. And this is important because, as we'll see shortly, that if a person is going through periods of slight highs, but their complaint is of depression, in other words, as far as the person may be concerned, they suffer from a depressive condition. If you don't spot those little highs, you can't actually switch off the depressions, because they're linked with one another. So in other words, that for certain types of bipolar, the more severe forms of it, what's called bipolar 1, which I'll define in a moment, it has been said over the years that about 1% of the population in the course of their lifetime will experience this. But the point is that lesser degrees of bipolar disorder are extremely frequent and overlooked. They're overlooked because the person who is a little high, they're not going near a doctor to tell them they're in good form. In other words, for the person, it's a painless experience. It's only maybe when the person gets very agitated or is in trouble at home or at work or with the law because of their mood disturbance that maybe the penny drops that there is something seriously wrong from a mood point of view, and then it gets properly diagnosed. So let's look at some of the symptoms and signs of bipolar disorder. Many of you are familiar with the standard symptoms of depression, where you have a disturbance of feeling, where the person is feeling low, where the person's energy is reduced, where the person has difficulty with sleep, and where the person's thinking is slowed down. So, in other words, what we call the festival symptoms. So, mood, in other words, feeling low. E is for energy, S is for sleep, and T is for thinking. So they're the core symptoms that you will experience in depression and elation. Feeling down, energy down, sleep broken or oversleeping, and thinking quite slowed down and having impaired concentration. Now, in elation, you get the complete opposite. The person feels euphoric, couldn't feel any better, tremendous energy. The person has great trouble sleeping at night, getting off to sleep, and the person is having racing thoughts, jumping from one topic of conversation to another, and thus being impulsive and very much all over the place. So, what we now need to do is to look at some of the core aspects of a model that would help you get a handle on bipolar disorder. And a useful model is this, that if you imagine that within the head we have a thinking wheel, we don't, but just imagine we have. We think at a certain rate. And we accept that rate of thinking. But one of the first things that happen when a person gets depressed is that this thinking wheel slows down. Words won't come to mind. The person has fewer thoughts. They say less in conversation, and they have difficulty projecting their thoughts out into the future. Now, what do I mean by out into the future? If I ask you, what are you doing for a break during the summer? Or what are you doing next weekend? Presuming you're not too depressed, something will come up on the visual display unit in your mind. That very process is weakened or absent during depression. So the person looks at the screen and you ask them, well, what's there? It's bleak, it's blank, or there's nothing there. They're the absolute three terms that people use to describe it. Now, because there's nothing there on the screen, the person then has very little energy, because energy is a figment of our imagination. We see something out there and we pursue it. Obviously, it's in our mind. In other words, I have to do this, I have to do that, I have to do the other, I have to pack the case, I have to do this. And we pursue it. So when a person doesn't have something there, or we see a mountain ahead of us on the visual display unit, it has a fatiguing effect. So here you have a person whose thinking is slowed down, who has difficulty taking in information from the world around them. In other words, its thinking process is moving so slowly that it can't take up the individual pieces of information from the world and put one in there, the next one in there, and so on. It can't string things together. So the person can't actually focus on what they are reading. The next point about depression is that when people are depressed, they tend to, when they're not able to project out into the future in that way, they tend to become introspective. And the two aspects of that being introspective. A person can be introspective psychologically, where they have an increasing awareness of everything they do. They feel maybe just self-conscious about their thoughts or self-conscious in the presence of others. For other people, it's a self-consciousness and awareness of their body. In other words, their skin, the colour of their eyes, the size of their ears, a headache that then maybe get from time to time and now grows into, in the person's mind's eye, a tumour. In other words, something very serious. So in other words, what happens is that with this introspection, you've got this hypersensitivity to things. The next thing is that the person tends to go back and think about the past because they're not really going to the future. And people go back into the past and they will resurrect negative things from their past. Now, normally when we look at the past, curiously enough, if we're in good form, we actually talk about the good old days, how things were better, how people were more polite, how there were fewer cars on the road, etc., etc. But, they were neither good nor bad. As Shakespeare says, but thinking makes it so. So, in a sense, when a person goes back and sees things in a negative way, what will tend to happen is that with that negativity, the person will often attribute the mood they're in to their memory of the past. In other words, to say, I am depressed because of something I did in my past. And that is where the guilt feelings come from. But as soon as that depression lifts, lo and behold, that disappears. And you say to the person, well, you were saying that you got involved in something in the past when you were depressed, and now that you're out of depression, can we talk about that? What are you talking about? It's gone as far as the person is concerned, and it has little meaning for them. Now, the point is then when you move to the elation, you get the complete opposite. What's happening now is the thinking wheel is going very quickly. And because it's going quickly, the person will often have a sensation of pressure in their head, as if their head is about to explode. They will have 1,001 thoughts, and not alone do they have a visual display unit on which are interesting things. The person will have plenty of visual display units. And as you're looking at the person, they're looking at this one, and then their mind hops to this one, and then to this one. So, in contrast to the person who's depressed, when they're looking at the visual display unit, they're looking vacantly into the future. And it's as if the world is empty to them. Whereas this person in the high state sees one thing, then another, and you see their eyes glisten and dance, literally, shifting over and back even as you're talking to them. And thus it's hard for the person to take on board what you're saying, because their mind is going so quickly they just can't absorb further information. They have tremendous energy because there are things here they want to pursue. They will chop and change in conversation, be impatient, impulsive. Often then they can only see things that are positive. Here we had, in the depressed state, person maybe can only see what's negative. So the person's thinking is much more in the future, and it's about positive things. And this is what leads to poor judgment. Because in a sense, when we come to a decision point with our thinking, we have a choice of, is this overall a positive move or a negative mood? And what happens then is that if the person only sees a positive thing, they come again to another one and it's just positive. So, for example, a person might say, I think I'll go on a holiday. I'd really like a holiday. The negative side there just doesn't get a look in. The next positive thing is, I really like this brochure. I think I'll bring my family. Next thing is, I think I'll bring all the family. John down the road hasn't had a holiday for a long time, and on we go. So it's that sort of anatomy of judgment that slips when a person's mood is disturbed. Now you get the converse when somebody is depressed. They can't get beyond the first thing. So in other words, maybe less money is spent on food. Maybe the heat is turned down. Maybe stock isn't ordered for the shop. Animals are sold off. Farm isn't stocked. So on. So you can see how these contrasting pictures suddenly begin to make sense, and probably can all be tracked back to one central phenomenon. Okay. So in other words, that the treatments that are used are often focused on trying to quicken the wheel or slow it down, depending on the state the person is in. Now, having looked at it from that perspective, we need to go and look at the symptoms then at another level. And what's necessary here is to look at, first of all, the different grades of depression and elation. So we just call it severities. So starting with depression. The first is that when a person is mildly depressed, they feel tired, have difficulty concentrating, they're often anxious. And often the symptom of anxiousness as a feeling precedes any feeling of depression for a lot of people. And they may even have a panic attack even before they feel depressed. And the other one then is self-conscious. When a person is, so that's mild, moderate, and severe. So in a moderate depression, a person has all of the symptoms that I've described. The withdrawn state, being quiet, little to say, difficulty concentrating, finding everything a bit of an effort, everything is uphill, everything is a problem, maybe being off their food. Generally, the person feels worse in the morning than they do later in the day. Typically, the person's sleep will be that they're waking up repeatedly during the night and or oversleeping and or sleeping during the day. When a person comes to a severe depression, what they often have are very negative thoughts, where the negative thoughts take over and produce what we call delusions and or hallucinations. Now, it's important to remember that in a depressed state, those fixed false ideas, which delusions are, they're fixed false ideas which have no basis in reality. They're nothing more than the negative thinking that is part and parcel of a mild depression. In a mild depression, a person might feel they're not a very worthwhile person, not a very good mother or father, or maybe they'd be better off if they left the company they work for, but they do nothing about it. Moderate depression, it's more intense. The person might start making remarks to other people about these thoughts. But here, when it gets more severe, the person actually is firmly convinced of it. They'll feel they're useless, worthless people, will feel the world will be better off without them, or they may actively ask people around them, would they help them get out of this life? On the other hand, the person may feel they've got some terminal illness and just see that as a release. Now, very often, the hallucinatory experiences where a person is having voices or visions, they may, in extreme cases, just be part and parcel of that picture. But it's very important for people who have these experiences just to be open about them, because they are something that is very treatable. And again, it's nothing more than an extension of what's there in the mild and moderate form. So when we look at elation, again, it's the same phenomenon. Now, you will know that when I mentioned mild depression, I didn't say the person felt depressed, because that's the curious thing about depression. See, depression isn't actually a great word to describe depression, and it has different meanings for different people. Often a person from an emotional point of view feels more anxious than depressed. And so in a way that when a person is going into a depression, what often tends to happen is they're very anxious at this point, and then they're anxious on the way out again. But down here, it's almost as if the anxiety switches off. In other words, it's the brain's way of shutting down the awfulness of depression. Now, curiously enough, it's actually here at these points that the person is more distressed. And it's often at those points, the points of entry and exit from depression, that people are more at risk of harming themselves. So when we look at the different grades of severity with elation, again, it's pretty much the same. So for a mild elation, the person might be feeling great. Never felt better. Confident. And great energy. Now, generally at this phase, nobody will know that there's anything amiss with the person other than their immediate family. Generally, work colleagues, extended family won't spot it. It's only people who are living with the person can see the contrast between the person they knew and what's there now. Moderate illness, the person is overactive, over-talkative, says things to people that are out of order, quite disinhibited in what they say, what they do, maybe the clothes they wear, sexual activity, the amount of alcohol, street drugs they might engage with, have often very little sleep, and the absence of sleep then fuels the problem. Because one of the things you'll find about bipolar disorder, if you want to start a manic episode, just stop the person sleeping, because 2 or 3 nights without an adequate night's sleep is often enough to trigger it. So in the severe phase of the illness, what happens is the person again has these delusions and hallucinations, and/or hallucinations. In other words, the person may see themselves as all-powerful, or feel that they're going to live forever, or they can cure anybody, or come up with great inventions, or sort out the world's political problems, and be quite convinced of this. Now, again, it's important to remember that those features are just as treatable as these. In fact, in many ways, more treatable, because what tends to happen is that when a person is that severely unwell, it'll be evident to everybody, and they're more likely to get help fairly quickly. Often people with mild forms of it accumulate enormous debts, will often have given away an awful lot of their possessions, and maybe the possessions of others, and that causes a lot of heartache. Next thing I want to deal with is where there's a diagnostic difficulty, and this is with what are called, you'll often hear the term, mixed mood states. When a person is going through a high like this, almost everybody, if not everybody, in a high state has periods of time where they're a bit weepy, a bit agitated, distressed, feeling hopeless. And if you ask them at that point, how are you feeling? They will use the term, I'm depressed, to describe it. But any casual observer looking at it, well, 10 minutes ago he was talking his head off, everything seemed fine, delighted with the world, and the vast majority of time in this, that is the symptom or the way the person is. So the question is, how do you distinguish these types of conditions? Because what tends to happen is that if that person really is convinced they're depressed and they go to their doctor and say, I'm depressed, how can the doctor distinguish that from a depression proper? And this is one of the big problems in treating or recognizing bipolar disorder. Because what tends to happen is that for a certain percentage of people, in fact, it's said that up to 30% of people who are in highs are in these mixed mood states. In other words, the person is saying categorically they're depressed, what's the difference between this depression and that depression? And the reason it becomes important is this, that it's said that something like 30% of people who have recurring depression have actually bipolar disorder that's gone undiagnosed simply because they're so vehemently depressed. And it's hard very often for clinicians who mightn't be experienced in this area to actually recognize it as such. Now, this has enormous consequences because if you treat this with antidepressants, that's what you get. In other words, you worsen the situation very significantly. So let's just look at the way we separate these things out. Now, this is also known as dysphoric, meaning unpleasant feeling, mania, as I said, speeded up, or hypomania. So in other words, what's happening here is this. As long as you remember that the core aspect of depression is that it's the slowed down thinking and physical state. It's like a flat battery syndrome. In an unpleasant high state, or a mixed mood state, or a dysphoric state, these are all interchangeable terms. The key thing is that the person's mind is still overactive. So in other words, even though the person says they're depressed, when you look at them, very often you can't get a word in edgeways. It might be an angry state, it might be a hostile state, it might be a very frightened state, but you still can't get a word in edgeways. The person typically has trouble getting to sleep at night. Whereas somebody with depression generally doesn't have trouble getting to sleep at night. In other words, if somebody with depression has marked trouble getting to sleep at night, the first thing you need to think about is, well, is it depression? The second thing is the person's eyes are lively, whereas the person in a depressed state, they're vacant and staring into space. So let's just from a symptom point of view, from your own point of view, how would you distinguish the two? Because they're very, very important. So it's relatively easy in some senses. So what's happening here is this, if we just draw it in this way, that if they're all the symptoms of depression and they're all the symptoms of the unpleasant mood state, they almost overlap one another totally. So I'm just going to tell you what the distinguishing symptoms are between the two. So the first one is trouble getting to sleep. Anger, and if you don't like that word, irritability. Number 3 is worse in the evenings. Depression tends to be worse in the mornings. So in other words, this is the unpleasant high state we're talking about. Worse in the evenings. So trouble getting to sleep, having anger or irritability, tending to feel worse in the evenings, and tearfulness. Now, this one isn't too reliable, the tearfulness bit. The reason I'm putting it in is that, just to emphasize the point, that frequently when people are clinically depressed with bipolar depression, during the depressed mood state, the person's is not generally cheerful. You see, in this unpleasant high state, it's an anguish state. It's a torturous state. It's a very, very unpleasant state. The risk of somebody harming themselves in this state is actually much greater than in a depressed state. And in fact, probably a lot of the suicidal attempts associated with bipolar disorder are in these states, mistakenly called depressive states, depression states, for years and years. The amazing thing about this is that this condition as such was recognized back in 1910, the early part of the 20th century and towards the close of the 19th century. And surprisingly, it just got overlooked within clinical practice, and it's only now recognized for what it is. And the reason why it's important is this, that frequently with people with recurring depression, what you'll find is when they describe it, they will say, I get depressed for X period of time, and then I'm okay for a few days, weeks or months, and the same thing happens, and again. When you ask the person, do you ever get too well? Do you ever go through periods of time where you seem to need little sleep? Do you ever go through periods of time where you're overactive, over-talkative? No. Sometimes when you bring in the family and interview them, they'd say, well, no, generally not. You can't blame the person being in particularly good form when they come out of a depression. They deserve a period of wellness. But when you actually get the person to start documenting it, what you find is it's actually substantial enough. So each time the depression ends, there is this high. Now it's this high that seems to contribute to this, the next one. In other words, that upswing in mood seems to be associated with this. So if you didn't see those upswings and just treated it as depression, you'd be missing the point totally. Because what you'd be doing is this, you'd actually be exaggerating the whole phenomenon. What happens is that if you put in a mood stabilizer here and stop the antidepressants overacting at this point, eventually what happens is that the mood pattern goes like this. Over a period of time, once the high stops happening, what you'll find is then the depressions begin to they just fade out over time. Now that can take months, even up to a couple of years. But the whole thing is trying to find this particular phenomenon as part of what's called bipolar 2 mood disorder. In other words, it's really a diagnostic problem. Bipolar 1, and this is where the person has a large high, frequently followed by a large low. Now, by definition, that is a high that's bad enough to land the person in hospital. It's just a rough definition of it. But it's where the person has symptoms of an extreme degree for at least 1 week. But that's just from a definitional point of view. Very often these phenomena go on for weeks and months untreated. Bipolar 2 is where the person has a lesser degree of high and then a low. In other words, that's what we call a hypomania. In other words, it's something that's much shorter and much less disruptive and may be overlooked. And all we may hear about is the depressive aspect because the person is relatively unaware of the high. Now, bipolar 3 refers to a pattern similar to this, maybe where the person is getting high after the low, but it's happening because the person is on an antidepressant. In other words, they were depressed, they were commenced on an antidepressant, and their mood picked up and went over the line. So you might say, well, stay away from antidepressants. Yes, relatively speaking. But the point is, if you do that, the person remains down there. So the issue here is that we need to keep this within the spectrum. We now talk about the bipolar spectrum. To acknowledge the fact that there are different severities of this condition, some where the high is very mild, but at the same time, it's of great clinical importance, because if it's overlooked, the point is the person's mood remains in free fall. Yes, we do tend to use as little antidepressants as we possibly can when treating bipolar depression, because it increases the chances of the person's mood going up and down. But what we've got to do is, first of all, deal with this, try and prevent this recurrence of mood, recurrence of the high, and bit by bit it fades out. If you stop the antidepressant, the person just goes down and stays there. So it's often a matter of trying to get two powers equally balanced. One is the antidepressant helping the person up, and then something here that blocks it going beyond a certain point. Now, the other point is that there's a subgroup of people within bipolar 1 who have highs only, but it's still by definition called bipolar disorder, even though there aren't at this stage two poles in the condition. Very often this is a condition or what we call recurring unipolar mania. It's where the person often has a very severe illness, quite disabling, of a manic nature, that will be quite disruptive in the person's life. But when they come down out of the high, they dip ever so slightly below the line, and all they might complain of is tiredness. But you will frequently notice that the word depression is never uttered by the person. As far as they're concerned, it's just a high. Now, the reason why this condition is so difficult to manage is that because the person doesn't have much pain from this phenomenon, the difficulty the person has is of heeding treatment recommendations, sticking with advice, taking medication, whatever it may be. Somebody's had a good whack of depression behaves otherwise, because they have a very big vested interest in doing whatever they can to stay well. Now, as a result, for people with this, it can have quite a disabling effect. Often people lose their employment, marriage, house, any finances. So just let's look at treatment for a moment. When a person is going through a big high like this and coming out this side, there are a variety of different medications used to try and help contain this. And they often come under the general term of anti-manic medications, but often on the market as antipsychotic medications. Basically, the focus is on trying to slow down the person's rate of thinking such that they can contain themselves and their increased energy and dynamic nature that is beginning to get them into trouble. Now, very often what these compounds do is they take the top off the condition, and very often there's a sort of an aspect of it still there beneath it. The other class of tablet or medications that's used are called anticonvulsants. So amongst these antimanic things would be things like Zyprexa, Severity. I'm using trade names here because you may or may not know the other names. Risperdal, Serenase, so the second group are anticonvulsants. Now, what the anticonvulsants do, things such as Epilim and Tegretol and Trileptal, they seem to have a calming effect on this, and probably Epilim is probably the most effective one for the severe elations. The final mood stabilizer for this condition is lithium. And it is by far the most effective treatment because it had lost its reputation as a compound over a period of years simply because it wasn't being marketed and is very cheap, costing pennies as opposed to hundreds of euros. Nobody was promoting it or doing research on it. But research over the past 5 years has shown that it's actually not alone superior to these, but also has fewer side effects. Many of these compounds, although effective, produce a lot of weight gain, increase people's cholesterol and blood glucose. Whereas lithium has its own issues, maybe around renal function, but by and large, if that's carefully managed over the years, people do extremely well on it and have a longer lifespan, better quality of life, and a more, by far, much more stable mood. What lithium tends to do, if you observe it carefully, is that when the person starts on it, almost over a period of 2 weeks, if they're on sufficient lithium, their mood comes down like that. Almost you could set your watch by it. Now, it doesn't work for everybody, but it does work for the vast majority of people with a severe, straightforward elation. And very often what happens is the person is put on some of these antimanic medications while waiting for the lithium to kick in, because it's very difficult for people who are high to be patient and take medication and maybe stay in hospital at a time because their mind is going so quickly, they find it hard to cope with it. The problem with episodes of elation is that almost always they're followed by episodes of depression. Even in people with unipolar mania that are referred to later, if you follow up people like that over the course of their lifetime, that maybe in their teens, 20s, maybe early 30s, it's mainly highs, but as they get into the middle years, it's surprisingly more depressions then that begin to emerge. So when that depression ends and is treated, the person may be well for X period of time. In days gone by, it used to be said that the chances of a person having a second episode was about 50%. We now know that it's actually much higher than that, and probably 70, 80, even 90% in some studies. So this is why a preventative approach is needed for the next episodes. And the choices are generally between those three categories: the antipsychotic agents, the anticonvulsant agents, and lithium. Generally, the treatment of choice in this instance, where you have a high followed by a low, the treatment of choice is lithium. Now, for people who have what we call the bipolar 2 pattern, where it's a big low and a certain amount of high, the treatment of choice here is, first of all, to try and get the person up out of the depression with an antidepressant. And if the high is significant, to use an antidepressant plus a stabilizer. Now, in this instance, the anticonvulsant stabilizers do seem to be more effective. In other words, things like Epilim, Tegretol, Trileptal are particularly good at sorting this out. Now, it means, number one, reducing the antidepressant, number two, putting in a mood stabilizer, and trying to work out a balance between those two forces until the person is on a sufficiently low dose of antidepressant or no antidepressant plus a stabilizer. In other words, if a person was on a stabilizer on its own, that person may be depressed. Another person mightn't be. So you've got to vary the doses of the stabilizer and the antidepressant until the pattern of swinging begins to settle. There is another pattern called rapid cycling, and this is where a person is having 4 or more of these episodes in the course of 12 months. For some people, though, it's even more rapid than that. It's ultra-rapid cycling. Now, frequently you'll see this pattern postnatally, or if somebody is on an antidepressant and they're very sensitive to the antidepressant, it can bounce the person's mood around quite a lot. If a person is on certain drugs such as steroids, or if a person had, we say, a woman had her ovaries removed, so it seems to be some hormonal phenomenon that leads to that greater instability in mood. That person may have had a relatively straightforward mood pattern that was relatively treatable, but hormonal changes seem to have an impact on it. And again, it's more often the anticonvulsant mood stabilizers that are helpful here. Lithium will work for some people, maybe for 30% of people with this. So there's often a lot of work over a period of time trying to find out the best compound for these. Main causative factors in bipolar disorder are genetic, such that we know that on average, that if this bar represents 100%, on average, 70% of the contribution is genetic and the other 30% is environmental. And we know this from twin studies, adoption studies, twins reared together, twins reared apart, that this statistic seems to hold true right throughout the research done over a 100-year period, really. But that average is made up of all sorts of different figures. It might be the other way around for some people, where it's 70% environmental and 30% genetic. And this may be where a person has a very vague hint of bipolar disorder in the background, maybe somebody in previous generations who got a lot of depression. We don't even know if they had a high, or they might have been a binge drinker. But in that person's environment, there's been a lot of trauma in their past and probably more so in their present life. For somebody else, it might be 90% genetic and 10% environmental. In other words, in this instance, the person became ill when little or nothing had gone wrong in their life, but they have a very, very, very strong family history of bipolar disorder. So you get all of these variations. When we look at the genetics of it, we don't have any clear understanding of what genes are involved. What we've come to discover is that it's wildly complex. It's more complex than diabetes, blood pressure, heart disease, any other phenomenon. And it looks as if there are a whole lot of mechanisms from a genetic point of view in the mind that are important in this instance, and we don't really quite grasp how these begin to play a part. What do we know about the environmental factors? Well, the environmental factors are the usual stress factors and stimulants. And the stimulants are bucket loads of coffee, high energy drinks, street drugs, amphetamines, cocaine, steroids, certain medications, some homeopathic remedies, anything that is a stimulant can do it. So in other words, what might be a mild stimulant for the average person and a pick-me-up, as it were, for somebody else who has a vulnerability or a family history of bipolar disorder, it can be the thing that kick-starts the illness. And then the other big heading, the 3 S's, are social rhythms. If a person who has a tendency to bipolar disorder has, for some reason or other, been unable to get to sleep, might be prolonged pain, might be sunburn, might be too bright outside, whatever it may be, or working alternating shifts at work, that upsets the biorhythms, the circadian rhythm in the brain, which in turn creates almost a jet lag type phenomenon within a person and can totally destabilize a person's mood. So these factors are actually quite amenable to intervention. So, for example, staying away from coffee and other stimulants, avoiding steroids unless you need them for something that's life-threatening, getting to bed at a fixed time, getting up at a fixed time, being careful about observing what effect shift work has on your mood, and if it has an effect, to bring it to your employer's attention. So fixed bedtimes, fixed rising times, fixed meal times are extremely important. We also need to, I'm afraid, put in cigarette smoking amongst the stimulants. It's been shown that certain aspects of cigarette smoking have a measure quite akin to antidepressants. Who didn't know that? The first thing is to acknowledge. It might seem elementary, but for many people, they don't get off the starting blocks because they can't acknowledge what's going on, even though intellectually they might know it at a certain level, but at another level, nobody's business, this is my illness, stay out of my space, etc., etc. But a lot of that is the illness phenomenon itself. So it can be hard for people when they're maybe a bit high to take on board what this illness is doing in their lives. So being able to acknowledge it means being able to say it to family, what's going on, maybe to some close friends, not to everyone on the street, please, but just keeping it in a small circle. And because, again, when a person does that in a public space, and I mean public within the family, they're actually beginning to take responsibility for what's going on. They're prepared to share what they're going through and to take pointers from others and support. Learn the facts about the illness. Often for a diagnosis of bipolar disorder is frightening for people. They don't want to hear the word. The biggest dread of anyone with depression, did you say I was bipolar? In other words, not me, please, don't say that to me. But the point is that often a person with depression has to take that on board. It might only be that size, but we have to put some sort of label on it in a way to help the person get a handle on what the treatment is about. Otherwise, they're actually quite lost about it. So, learning about the illness. Number 3 is getting emotional support. Talking to others who have the condition and who've been on that road before you. Through support groups, Aware Support Group is an excellent way of meeting people who know what it's about. You might think they can see around corners. See, many people, for example, who come along to Aware Support Groups will find out in the course of their attendance at the group, they've come along with depression and they realise, yes, they do actually have symptoms of being high from time to time. And then once they can bring that information back to their doctor or therapist, it can be factored into their treatment plan, and it makes a hell of a difference of how they manage. Now, once the person is on board about doing something about it, this is the key thing, spotting a relapse. If a person is going high and they can spot it quickly, I mean within hours of what's happening, it means it doesn't intrude into their family life, into their work. It doesn't means that there are fewer altercations at home around it, or time off work, or loss of study time, and so on. So how do you spot it? Well, you can take the ordinary signs and symptoms I've given you. That's fine for depression, but it's pretty hopeless actually for elation, because elation is a relatively pleasant phenomenon for the person concerned. The second way to spot a relapse within yourself is to know what your personal sign is. What do I mean by your personal sign? When somebody's high, everybody does something that's characteristic of them that they wouldn't be seen dead doing otherwise. Wearing a certain pullover, buying certain items, wanting to go out the back and sow an acre of potatoes. Never think about it other than when high. Suddenly smoking, a non-smoker suddenly taking a cigarette. Now, the point here is that the family know from the person's previous behaviours during highs that that's what Tom or Mary does when their mood is gone. In other words, that is all from the first sign, and it's personal in the sense that one day it's not there, the next day it's there. The trouble with a lot of the things like sleep disturbance and so on is it when you have a half an hour's trouble getting to sleep, or an hour's or 2 hours, that you call it sleep disturbance. In other words, the person would say, oh, well, I just was a bit excited that night, or I had too much coffee or something. Ultimately, though, both of those things are inferior to the next one, and that is picking somebody whose judgment you trust, preferably somebody you're living with, and asking them to tell you if they think your mood has gone up. Simultaneously, you've got to give them permission to act on your behalf. That might be, if you see me in that state again, please take away the car keys, get me to the doctor. Even if you've got to get me into hospital, I give you permission to do that. Okay. That doesn't get abused, I can assure you. I've never seen it abused. What tends to happen is that when a person has a safety net like that, lo and behold, they don't end up in hospital, because it's spotted early, treated early, and dealt with very effectively. The 3 S's: bed at a fixed time, up at a fixed time, regular as monks. The stimulants: coffee, anything that you find that gives you a buzz. Most people know when they've taken something, I need to be careful about that. It's often best to keep below that level where you find it's affecting you. And obviously trying to limit stress in your life as best you can. It's probably true to say that mindfulness in reducing stress in a person's life will be shown to have a lot of effect on reducing the relapse rate where stress is a factor in a person's bipolar illness. The final item is talk over the past. When people are depressed, but more particularly when they're high, they will do things that upset others. And very often that gets brushed aside when the person is unwell, and then the person themselves doesn't particularly want to bring up a thorny subject when they're recovering, and the family don't want to do it either in case it upsets the person. So it gets swept under the carpet. But if that happens a few times, somebody begins to trip over that carpet, and suddenly relationships end, marriages end. Whereas if the person can be encouraged to bring out the hurts into the open and speak about them openly, it prevents that happening. So what we advise people is, when the person's mood is stabilised, not when they're still high, not when they're still low, when their mood is stable, to talk to the person they think they've offended and say, look, when I was high the last time, I called you X, Y, and Z, or I did such and such, or I spent all this money, or whatever. I need to apologize to you for this. I take full responsibility for it. Okay, yes, it may be illness-based behavior, but if the person is going to benefit from being honest about it and taking ownership of it, they have a less chance of doing it again. It's just facing the pain of it. The relative in question or the friend might say, oh no, forget about it. No, the person, that friend, needs to let the person say what they've got to say. If they shut it up and it's not expressed, that friend, relative, will hold a grumbling resentment that will eventually cause trouble. Thank you for your attention.